This is a very short, high-level webinar. It's to mark the release of Recovery Beyond Survival, which is a review of the rehabilitation care patients got after an admission to a critical care unit. We're going to hear from three speakers. We're going to ask Professor Zudin Puthachuri to talk about why he proposed the study. You're then going to hear from Professor David Williams, who has run the study, along with Alex Goodwin from within NCEPOD. Alex couldn't make it today. And then we're going to hear from Sean Sahar, who's going to tell us about what the report means for patients. And Zudin, I'm going to ask you to start, if that's all right.
Thanks, Marissa. Good afternoon, everybody. I'm Zudin Puthachuri. 80% of our patients survive critical care to be discharged from hospital. This survival comes as a cost. In 1 year, 50% of our patients haven't returned to work, and a third of them need help with the basic activities of daily living, like going to bed, getting out of bed, going to the toilet, brushing their teeth. Rehabilitation after critical illness isn't funded, it isn't commissioned, and there isn't a pathway for rehabilitation out of the hospital into the community. So our patients are having to navigate this journey themselves while simultaneously dealing with their new disabilities. Patients and families tell us all the time that they feel abandoned, they struggle, and the ramifications of this go on for years and years. This personal cost to our patients and carers has impacts on the NHS. 50% of these patients will return to hospital within a year. And we hope that this NCEPOD report will then form the basis of how we can go forward and communicate and engage with commissioners, with politicians, and with clinicians to make sure we can actually provide the rehabilitation services that our patients need.
I get the pleasure now of sharing the findings of the report and the recommendations. As Marissa mentioned, I'm doing this on behalf of myself and Dr. Alex Goodwin, who unfortunately couldn't be with us today. I think what we can show is, with the NCEPOD methodology, is just how many data sources are used for this. So I think the first thing to say is a really big thank you to everybody that's been involved, from those in the specialist advisory group who have helped to develop and refine our methodology and data collection instruments, the case reviewers who spent a long time going through the individual case notes of patients to really pick out the key themes and findings, and importantly, the people here at NCEPOD, so Hannah and Dee particularly, but the researchers that do a lot of work in the background to bring all of this together. And I think you'll see the scale of what we've done over the last 2 years as I start going through the report. So as per the standard NCEPOD methodology, there are multiple different data collection methods. So one of the cornerstones is the review of individual patient case notes. So you can see here we reviewed 671 sets of notes by the clinician responsible within that person's trust. And also then 365 sets of case notes were centralised here at NCEPOD and reviewed by an expert case reviewer team from the multidisciplinary team. And this was using a standardised pro forma to look at various different aspects of care. To give you an idea of the patients included, so our study population were those adults over 18, admitted to the intensive care as an emergency, staying for at least 4 days and being discharged home, so we could test all parts of the pathway, and that was between October and December 2022. And the reason we wanted that discharge home was we reviewed the care provided both within the ICU, in hospital, and then up to 12 months following hospital discharge, so we could really see what was happening. Another key part of the NCEPOD investigation is the completion of organisational questionnaires, and this is where we asked trusts to provide information about the services they provide, the policy and procedures in place, and how care is delivered. We also completed primary care questionnaires where we got organisational results from GPs, as well as the review of GP case notes related to some of these ICU patients as they've been discharged to community, 67 community trust questionnaires, and then we surveyed 102 patients and 420 healthcare professionals to ask their opinions about care. So as you can imagine, this generated a lot of information. I could certainly take all day presenting this all back to you. So what I'm going to do now is just go through the key themes and the key findings. So the first one was linked really to coordination. And I think the biggest thing we can recognise, although our intensive care patients have a standard point of entry, they often come from a multitude of different specialties, with a multiple different presentations and clinical presentations, and often leave intensive care with multifactorial rehabilitation needs. As they're stepped down through the system from ICU to the wards, they can go to a variety of different ward locations and ultimately then come down to the mercy of the receiving ward and the available services and rehabilitation in place. What this means is often there can be problems as patients transition through, and our patient partners regularly tell us that it can feel like falling through the cracks. When they leave intensive care, there's no real pathway for them to be supported. The rehabilitation can definitely vary, and actually they don't always get what they receive. And the lack of oversight and coordination was something that came through quite strongly as patients moved through the ICU onto the ward and certainly out to the community. Now, as we surveyed organisations, we found less than half of organisations had a policy or standard operating procedure for the delivery of rehabilitation. And even those that did, only around a third undertook audits against these standards. And what this really came throughout the case note reviews and throughout the study was there's a bit of a disconnect between what organisations reported and what they felt was happening and what was actually being delivered as care within the trust. We regularly saw data suggest there was an absence of teamwork and communication, and this often resulted in quite siloed approaches to rehabilitation delivery. So healthcare professionals very much focusing on their own area of expertise, physiotherapy, potentially looking at mobility, but not considering the wider aspects of care. It became very process-driven. NICE CG83, which was published over 15 years ago now, made a strong recommendation for the need for key workers to coordinate rehabilitation. And we found that these were rarely available in those patients we reviewed. Only around a quarter had a named key worker. Where they were present, they were consistently associated with improved markers of care quality in terms of the completion of comprehensive assessments, setting of goals, handovers of care, and just generally to coordinated care throughout the pathway. The second key theme which came through, which we probably expected at the time, was the initial and subsequent assessments of rehabilitation need were not always undertaken, and there was quite a large variation in terms of what was being provided. We found less than a third of patients had a documented baseline screen on ICU admission of their potential rehabilitation need and underlying social status. To evidence this, for example, 71% of patients had no baseline psychological assessment. And interestingly, when we looked at the population included, this was despite the fact 17% had previous contact with mental health services or underlying mental health conditions, 19% had a history of excess alcohol, and 9% had previous drug use. So despite quite a significant number of patients being admitted with psychological history, screening and assessment at that point of admission was rare. Now, we might think that that's because we were only assessing those that needed it, but this wasn't the case. And actually, a previous psychological history had no impact on the likelihood of this being screened on ICU admission. So there was a failure to capture information at baseline on admission. We then move on to the need for comprehensive assessments of need. As I pointed out before, patients are often left with quite significant and multifactorial rehabilitation needs. As part of the case note reviews, we found just over half of patients were reported having had a comprehensive assessment. Now, these were the reviews that were done by the clinicians within their own hospitals. When we reviewed these cases centrally as part of the MDT, the resounding feedback with these reviews were often not comprehensive at all. They predominantly were led by physiotherapists with a focus on physical function, but lacked consideration of the wider aspects of rehabilitation need. Non-physical factors such as psychological health, nutrition, swallowing, communication were often missing. And that led to significant impacts on the actual care that was then being delivered. Where the comprehensive assessments were done, 38% of patients did have their goals set. And when they were set, they were generally done at the right time. Only half of patients saw these goals ever reviewed or updated, and only 1 in 4 had an individualized treatment plan. Now, the lack of goals and the lack of policy was seen to significantly impact care and was considered to affect the quality of care that was provided for 2/3 of all patients reviewed. So there was a significant lack of comprehensive assessments, a lack of goal setting, and a lack of individualized plans for treatments. As patients move through the hospital and step down to the ward, it's acknowledged by multiple documents such as NICE CG83, GPIC, and other national guidelines that there should be a re-evaluation of patients' rehabilitation need to look at ongoing issues and to make sure the required services are in place. Our reviewers found this only occurred for around 1 in 4 patients who had a comprehensive assessment completed on the ward. And that again led to delays in the initiation of rehabilitation or even a complete lack of provision in certain circumstances. As patients were leaving hospital, just over half were offered a follow-up appointment, but of those who attended, only around half were then comprehensively reassessed. And there was a tendency to maybe look at some aspects of care, but not provide a thorough, holistic evaluation of rehabilitation needs as part of follow-up clinics. So there's a real lack of identification of rehabilitation need patients as they were admitted to critical care. The third theme, which came through repeatedly for all areas that we evaluated within ICU, on the wards and in the community, was that the full multidisciplinary team was rarely available to meet all of the rehabilitation needs of our patients. Certainly, the MDT staffing level failed to reach national guidance for any of the healthcare professions that we evaluated, and this meant that clinical staff were often shared with other areas, covering quite large patches across ICU, multiple wards, and understandably, this then limited the provision that could be given. Physiotherapy involvement was the most common in the case note reviews, with 90% of patients seeing a physiotherapist. But it's important to acknowledge, and our reviewers pointed out, that at times this was purely for respiratory care and didn't always relate to level of rehabilitation or rehabilitation provision, and dietetic involvement was the second most common. Room for improvement was identified in both the timing and the consistency of rehabilitation delivery for all staff groups. The biggest delays were seen with relation to OT and psychology. Around a third of patients, as they moved out of the critical care unit, had input from an ICU team. But this was usually in the form of an outreach nurse or a follow-up nurse, and failed to consider all aspects of rehabilitation. So there was a real lack of consistency in ongoing rehabilitation as patients stepped down from ICU to the ward. And again, patients were faced with either a lack of input, delayed input, or inconsistency in subsequent delivery. And at the point of leaving hospital, around a fifth of patients didn't have the required referrals in place at hospital discharge and were sent off to the community with rehabilitation need that then remained unmet. To try and improve communication, something that's regularly recommended is the use of multidisciplinary rounds or multidisciplinary meetings. And these can provide an ideal opportunity to complete or update comprehensive assessments, give everybody from the multidisciplinary team a voice, help with shared decision-making around rehabilitation progression or initiation, and certainly facilitate and review patient goals. Now, clinicians reported that patients were discussed as part of an MDT round in around 50% of cases. But actually, when our case reviewers reviewed the specific documentation, we only found documented evidence of an MDT round in 19% of all of those cases that were reviewed. And consistently, and probably unexpectedly to the people on this call, that was often due to the fact there was a lack of wider MDT involvement, a lack of consideration of all aspects of rehabilitation provision, and generally an inconsistent delivery to what was being completed. So there was a lack of communication across sites. And what that meant was there were delays again in the initiation. What we did find, because we did find, and this is all sounding quite negative so far, so I should say there are some really good aspects of care. And what we did find was if patients were discussed at an MDT, their overall care was 3 times more likely to be rated as good. They were 3 times more likely to have a comprehensive assessment and twice as likely as have goals set. So as a process measure, regular multidisciplinary team meetings improved key markers of care and were directly associated with a better overall care experience for our patients. The major challenge, and I mentioned this as we first started, was the complexity of patients coming into ITU, being stepped down to the ward, and then the challenges of being discharged to a multitude of different areas. I think one thing we saw really nicely during the COVID-19 pandemic was the creation of COVID step-down wards with full MDT provision. And these could work very well and ensure a seamless pathway. Now, when you have a multi-specialty critical care unit, this obviously doesn't, this isn't something that's possible. The surgical patients will go back to surgical areas, trauma patients back to trauma areas, for example. and therefore the coordination starts to get diluted down. Now, a key component to this process then becomes related to the handovers of care. At ICU step down, we found that 19% of patients had absolutely no evidence of any handover related to rehabilitation need. So 1 in 5 patients were leaving ICU with no consideration or mention of what rehabilitation they'd had in the ICU, what their goals for treatment were, or what they needed next. And actually, even where present, 76% of all handovers from critical care had information missing, and that was usually information related to the comprehensive assessment, the current goals, or the current rehabilitation plan. Now, what this meant was, as patients went to the ward, we often saw delays in the initiation of the required rehabilitation, or at times a complete lack of rehabilitation delivery. It may, for example, be somebody who was struggling with nutrition, with a disordered swallow, an NDT that had come out on their last day in critical care, and then there was no dietetic review, no speech and language therapy review, and a lack of nutrition for the first few days of arriving on that ward. So these are some quite stark impacts on the patient and their ongoing care. But again, flipping that round, what we did find when there was a very good, robust and documented handover process, you were much more likely to have better continuity of care and better overall ratings of care from our reviewers. This wasn't just a problem as patients transitioned from ICU to ward though, and at hospital discharge, only 1/3 of patients had a named key worker or somebody they had as a point of contact, usually somebody from a follow-up team. Without this, it meant that the GP became the main point of contact as patients went out into the community, and 86% of all patients reviewed attended for at least one GP appointment in the first year after discharge. Now, with the GP case record reviews, this gave us some really interesting information about what those reviews constituted, and half of all those GP visits were related to either ICU admission or ICU-related morbidity. Concerningly, we found that GPs were only aware that the patient had spent any time in the ICU in just over 2/3 of cases. So 1/3 of all admissions, either there wasn't a discharge letter sent to the GP, or the discharge letter that was sent didn't include any information about the ICU stay or associated rehabilitation need. Within that, 1/3 of all patients who visited the GP required onward referrals related to rehabilitation. The GP surveys provided some really important information here where they said themselves they had a lack of understanding about the specific impacts of a critical care stay and the wider needs for rehabilitation, and a lack of awareness of the rehabilitation services available. So a lot of patients were coming to the GP as a first point of contact for support, but the GPs didn't feel they were equipped to understand the rehabilitation need or what services were available. Again, though, we did see some really good examples in practice, and actually 1/3 of GP practices, once they receive a discharge letter that states a patient has been on ICU, that would trigger an automatic contact from the surgery to check in with the patient to see how they're getting on, either from a phone call or to bring them in for appointments. So there are some really good examples of practice, clearly some quite significant areas and room for improvement. The final theme, which is one that I think has come through in repeated examples of national guidance or evaluations in the past, was the need for better patient information and patient and family involvement in care. There was often no standardized approach to the provision of this information, either within hospital or following discharge. All About Me booklets are regularly recommended as a really useful tool to understand who the individual person is before they were the patient in intensive care, what their likes and preferences are, who their key individuals are, to try and personalize care. And these were present for around 1 in 4 cases. 41% of patients had an ICU diary. We found just under 1/3 of patients were given a copy of their ICU discharge summary, but these were often in medical terminology and not necessarily the most understandable for our patients, and only 51% were given a copy of their hospital discharge summary. The reviewers' opinions were that patients and families were involved and adequately updated in just over half of all cases. And this is something that resonated in our patient surveys, where we found only 40% of patients and families felt satisfied with the information they were given or the involvement they had in care, either within hospital or following discharge. So there's a real need to try and engage families more in the care processes, care decision-making, but also to provide information in an accessible way that can help support recovery. Now, one of the things that NCEPOD does as part of all of its reviews is at the end of that case, they ask the reviewer to rate the standard of care. They can identify any specific areas for clinical improvement, any areas for improvement in organisational care, or both. Now, what we found of all the cases reviewed, only 13.5% were rated as actually being good. 13.5% required improvements in clinical care, 12.9% in organisational, but overwhelmingly, you can see here, just over half of all cases needed improvements both in the organisational processes and structures, but also the clinical care delivery. So there's a significant need to improve services. What we did find as well, though, was certain factors that were directly associated with better care being delivered, and they were the presence of proper comprehensive assessments, the setting and review of patient goals, the use of outcome measures to monitor and track rehabilitation, and complete handovers. And all of those were significantly associated with better care delivery or the likelihood of care being rated as good. What did our patients and healthcare professionals say? Well, they really confirmed what we'd been finding through the case note reviews. So the patients on the left, and one suggested, well, when patients step down from ICU to a ward, this is where continuity often stops. I got forgotten by the ICU team. Once you've been to ICU, that connection should continue right through to discharge and beyond, certainly to GPs as well. One patient felt that once I was discharged, I was left on my own to get better with no other offer of assistance. And another stated, the information leaflets I was given gave the impression that the residual health issues would be short-term and soon resolved. For me, this has not been the case, and nearly 15 years later, I continue to live with the physical, psychological, and cognitive issues as a consequence of my critical illness event. These aren't isolated incidents, and I think as we read through the case reviews, we saw consistently patients that were being discharged from hospital with quite clear and obvious rehabilitation need, a failure for these to be met or addressed, and people then presenting either to the GP or follow-up clinic with ongoing residual physical, psychological, and cognitive issues that weren't being managed, and that having a very real impact on their quality of life. This was echoed by our healthcare professionals who said a proper, clear pathway to be followed for patients. As long as patients belong to different medical specialties, once they step down, who then have different priorities, rehab usually not being one of them, patients are always going to have inequitable care and poor outcomes. And I think we can get focused a little bit on the short term in hospital wards about new admissions coming in or getting people out of hospital. And sometimes those with more complex rehabilitation needs just aren't given the priority that they deserve or the wider coordination. And from a GP perspective, there's no information available in primary care as to what help is available for rehabilitation. The wait list for any community services in our area is so long that any input is irrelevant by the time it is received. Then snapshots and the headlines. As I say, it does make for quite stark reading. There are some really positive shining lights of what is good practice, but importantly, there's some really clear messages about what we could do to make this better. And I think moving forward, that's our role now to take this on board and really champion to make a difference for our patients. The report itself is available along with a number of other resources. There's summaries, there's infographics, there's audit checklists, and there's implementation tools. You can use this QR code to go directly to the pages that house the report and its associated guidance. I'd encourage you all to take a look. And I think there's some really useful stuff in there that can help to improve care. Now, I've chatted on for quite long enough. Hopefully you found that interesting. And I think we're going to go to the really important part now, which is Sean, who's representing ICU Steps, who's going to give us an overview of really what this now means for patients.
Thank you so much. Can you hear me okay, everybody?
Yeah, perfectly.
Fantastic. Thank you so much. And thank you so much for inviting us to be here today and asking me to speak on behalf of ICU Steps. So my name is Sean. I'm Sean Sahar, and I am a trustee for ICU Steps. I'm also doing a PhD funded by the NIHR, exploring family support after the intensive care experience, and I have a clinical role at King's College Hospital in London. So ICU Steps, just as a bit of background, was established in 2005 under the leadership of Peter Gibb and Mo Peskett, and it has three core aims to support patients and families affected by critical illness, to promote the recognition of the physical and cognitive consequences of critical care illness through educating healthcare professionals, but also the general public, and also to encourage research into the treatment and prevention of these issues. So emotional and cognitive physical rehabilitation is really at the heart of everything that ICU Steps does. And this is why we're really optimistic about the potential impact of this report. So I don't know if you're aware that ICU Steps receives contact messages. Every month we receive lots of messages from ICU survivors, from family members and some bereaved people. And these really echo what has been highlighted in the report. People talking about being like far along their recovery pathway, but still really struggling. Reaching that point of being discharged home, but then not knowing what is happening, not knowing what's normal, what do they expect? And really only just registering this is the beginning of their rehabilitation pathway. And then there's a really powerful message, the largest quote here, that somebody had been through a really traumatic experience, that trauma that had led them into intensive care, a long intensive care stay, and then she was recovering and feeling like she needed to be the one following up, like chasing up all of her appointments. She had no information about what to expect, and she felt that nobody understood what she was experiencing, what she'd been through. And I think this is really powerful, and I think the messages in this report really address all of these issues, and they have the potential to affect this narrative and to improve the pathway, the experiences for patients and families. So the impacts that we anticipate, that we hope will come from this, we think that by having a rehabilitation coordinator, a point of contact with the ICU, that's something that patients and families ask for all the time. They will be able to either remotely, digitally, or in person support people to actually navigate that rehabilitation journey, provide appropriate rehabilitation from the right team, and reduce their risk of having to chase up appointments themselves and having potential of being lost in the system. And we know that rehabilitation looks different for everybody, and what's normal for people looks really different. But the impact of having a individualized and a realistic goal for people that is input by the family members and by the patients themselves, that's so motivating, and it really helps people to push through the difficult periods, and take pride in the improvements that they see, however slow they might be. Crucially, providing information about what to expect from rehabilitation, it takes some of the fear and anxiety away from the process for both patients and the family members, and it can help them manage expectations about the physical and the emotional and cognitive consequences of being on critical care. So on the next slide, thank you. I wanted to highlight some of the things ICU Steps does, because I know I feel like as a healthcare professional, this can maybe feel a little bit daunting, but actually ICU Steps has been working really hard to co-produce a lot of information for families. So the information that's on the website and also available in booklet form has been written with family members and with patients to be accessible. So the information leaflet that's about the general guide for patients and relatives about intensive care, that's been translated into 19 different languages. So that's hopefully a really useful resource. But there's also individual leaflets that are available about worry after intensive care, about brain injury, about legal issues and things like this. There's heaps on there. So it's really worth exploring and seeing what's relevant to your patients. ICU Steps is affiliated with 18 different peer-to-peer support groups, which are either delivered digitally or in person across the UK, and you can refer people to those. There's an online health forum called Health Unlocked, where people can log on and share experiences, support each other, share information. And then ICU Steps Active is the newest initiative, and it's an online critical care specific rehabilitation program that patients can join for a period of weeks and get online sort of rehab specific to their needs. it's very full. People seem to really like this, and it has quite good outcomes. So there's a waiting list, but please do refer people to, and you can be a healthcare professional or patients can refer themselves. So please do look into that. So that's a very sort of like brief overview of what we feel the impact will be of this report. And if you do have any further questions about the charity or about anything that we've mentioned, please do get in touch.